Good evening and welcome to one and all present in this session. I am Ishika from ClearNet. ClearNet is very proud to be a part of this webinar as a digital partner. Now I would like to play a short video of ClearNet. Thank you so much for all of your patience. ClearNet is India's largest live digital CME and doctors-generated medical content platform. Our website is www.clearnet.com. Now, without further delay, I would like to hand over the session to Dr. Neha Patel, ma'am. Ma'am, you can start.
Thank you so much, Ishika, and thank you, ClearNet, for providing this platform. I welcome you all to today's e-Gurukul Pathshala, the PG clinic, which is very popular in all the PGs across the West Zone and even all the PGs in India. Today we have a case discussion on central nervous system, and for this we have two eminent experts. So I welcome Dr. Abhay Shah, sir. Sir is a gold medalist when he was in MBBS and MD both. He is at present director in the Children's Hospital and Pediatric Infectious Disease Center at Maninagar. He is a member of ACVIP from 2021, 18 and 19. And he is a national scientific convener of IAP Action Plan in 2021. He is very active in IAP and he was executive board member of Central IAP in 1812 and 2009. He was a chairperson in infectious disease chapter in IAP in 2015. He has many things in his bag, and he is on the editorial board of so many textbooks. We can like IAP textbook of pediatrics, which is there used by all the PGs. Even being in the bag are the textbook of pediatric infectious disease, textbooks of vaccine, immunization, PID, and whatnot. So I welcome sir. He is recipient of the Tapan Kumar Ghosh Memorial Oration in 2021. Sir, we are really very much fortunate to have you on this platform. Welcome, sir.
Thank you for the kind words. Thank you.
We have another eminent expert, Dr. Harsh Patel. He is a pediatric neurologist and he is a consultant at present in the Zydus Hospital, Ahmedabad, and honorary consultant and faculty for postgraduate pediatric neurology fellowship at LG Hospital and Medical College. He has so many publications in the international index journals, and he is co-author of the 6 books, including IAP textbook of pediatrics. He is one of the reviewer of Indian Pediatrics and BMC Neurology. Sir has received awards like Original Research on Epilepsy Tool, got the AIMS Best Clinical Research Award in 2016-17, and also for the Best Poster in ICNC in 2018. Sir will join us soon in 5 to 10 minutes, but I welcome sir in this platform for today as an expert. Today we have a presenter, Dr. Aarti Solanki. She is third-year resident in DNB in Department of Pediatrics at GMERS Medical College and Hospital, Sola, Ahmedabad. We have her mentor, Dr. Rashmi Thanvi. Welcome, ma'am. Ma'am is an associate professor in the Department of Pediatrics, and she is having a wide teaching experience of more than around 20 years. So, welcome, ma'am, on this platform.
Thank you, ma'am.
We are so much thankful for a project in charge, our Dr. Yogesh Parikh sir and convener Dr. Baldev Prajapati sir. Sir will not be able to join today because of his social commitments. And I am thankful to all my coordinators, Dr. Aarti Kinikar ma'am and Dr. Vaishali Joshi ma'am also. So now we are proceeding with the case presentation. And so Dr. Aarti, you can start.
Uh, Good evening, sir and ma'am. Myself, Dr. Aarti Solanki. Ma'am, can I continue?
Yes, please, Aarti.
Please go ahead. Yeah.
An 18-month-old male child born of second by birth order, born of non-consanguineous marriage, residing at Vatna, Ahmedabad, Hindu by religion, informer being parents, brought to us with complaint of fever since last 14 days, decreased activity since last 7 days, and one episode of convulsion today morning. Child was apparently well 14 days back. After that, he started having fever, which was low grade in intensity, non-documented, intermittent, responded to medication. Child was sick looking in interfebrile period. Loss of appetite for past few days. Child slowly became inactive. And most of the time lying on bed. The morning of the day of presenting to hospital, he had first episode of convulsion, which was jerky movement of all four limbs. A prolling of eyeball frothing from mouth was present, lasted for few minutes, not associated with fever, no urinary or fecal incontinence. On asking, mother had noticed that significant weight loss in form of loosening of clothes were present from last few weeks. No history of any head trauma, no history of ear discharge, no history of any vomiting or rash, no history of traveling, no history of any recent vaccination, no history of drooling or saliva or a deviation of mouth or squinting.
Okay, so Aarti,
Yeah.
you need to tell the relevance of your negative history.
Ma'am, child was having complaint of fever with convulsion, with decreased activity. So for convulsion, we should rule out any head injury which has led to convulsion, or any ear discharge which can also lead to spread of infection to CNS or to brain. So these both were negative. No history of vomiting is suggestive of raised ICT. If vomiting is projectile or persistent vomiting is there, child may have raised ICT. No history of rash. Mainly in measles or any meningococcal rash, there is a CNS involvement. In measles, mainly due to decreased immunity. Child have a immunocompromised state. So child is more prone to have infection. No history of traveling, no history of recent vaccination, and drooling of saliva or deviation of mouth and squinting, mainly indicating any cranial nerve involvement is there or not.
So why have you asked the history of travel? We know the always the negative history helps you to rule out the things which are there in your mind after the history. Okay, so with this, you are trying to either ruling out or trying to get some more evidence to whatever is there in your mind as a diagnosis as per your present history and ODP.
Yes.
So with this, you have suggested all the things that what was there in your mind. But so what is the relevance of travel?
Ma'am, if child has traveled to some endemic state where Japanese encephalitis is common, so we can suspect in direction of that also.
Yeah. So you go to the first slide, please.
Yes, sir.
Yeah. So here history since 14 days, decreased activity since 7 days, and once episode of convulsion. So there is a new onset of convulsion. There is fever.
Yes, sir.
There is decreased activity, and sometimes child is also some altered sensorium. So if you want to coin a term, which term would you like to use for this constitution of the symptoms? You got my question. There is a specific term which is coined for this type of the constitution of symptom where there is fever, encephalopathy, and new onset of convulsion, which is not a febrile seizure.
Sir, acute meningoencephalitis or acute encephalitis.
Yeah. That is different diagnosis. But what is the term that is used generally by WHO for the surveillance purpose? Have you heard the name of acute encephalitis syndrome?
Yes, sir. Acute encephalitis syndrome.
So that is the word term is we coined, and then there are different diagnoses, what Dr. Nehal madam was telling. Yeah. Then you have said there is no history of rash. So can you tell me one condition or encephalitis where rash is present, then we rule out that particular condition. If rash is present, then that encephalitis is not there. Which is that? It's very specific.
Sir, chickenpox?
No, chickenpox rash. Chickenpox is having rash. Here there is no rash. Means presence of rash will rule out the diagnosis of one encephalitis. What is that? So it is Japanese encephalitis. In Japanese encephalitis, there is no rash. So it is a very important clinical finding that if rash is present, most of the time it will rule out the diagnosis of Japanese encephalitis. Yeah, please go ahead.
No history of tuberculosis or measles or any hospitalization. No significant family history, but on asking, mother was saying that she was having coughing since last few weeks, which was treated on OPD basis and no workup done for that. No history of tuberculosis. This child was second by birth order. First child was female, who is 6-year-old. Antenatal history. The child is second by bond of non-consanguineous marriage. No significant antenatal, natal or postnatal history. Routine ANC visits were taken. In first trimester, no history of fever, rash or any other complication. Folic acid was taken regularly. No history of drug intake or radiation exposure. No alcohol, tobacco or substance abuse history. The second trimester, TD taken 2 doses 1 month apart. Iron and folic acid and calcium were taken. Anomaly scan done and no abnormality was detected. So no documentation were available for that. Third trimester, appropriated fetal movements noticed by mother. Adequate weight gain was there. No history of fever or UTI. No bleeding per vagina, false swelling, liquor or premature rupture of membrane. Natal history. Child was full-term LACS in view of previous cesarean section. This was male child, birth weight was 2.5 kg. Child baby cried immediately after birth and no history of financial state. No significant postnatal history or any admission or complication.
Okay, so Aarti, with your presenting complaints in the case, are you suspecting any illness origin that is starting from the pregnancy or birth?
No, ma'am.
I appreciate you have taken a very elaborate history of all the trimester and the birth, but are you suspecting any relevance with the birth or the antenatal history?
No.
So it's an acute, which is after around 1 year. Mostly after 1 year, something has happened to the child, which is acute, with the fever, with the loss of weight, and the insult is also involving something in the CNS because the child is having convulsion and something like apathetic. Okay. So it's not involving a long process or a chronic process, which is having impact starting from the birth. So what does it rules out?
Congenital, any congenital anomaly or congenital defect, or any inborn error of metabolism.
Yes, very nice. One is inborn error of metabolism, which leads to convulsions. Then?
Birth-related injuries or hypoxic injuries to the brain.
Yes, so HIE and its sequelae.
Any metabolic abnormality like hypoglycemia at birth.
Yes, that is very important because even in asymptomatic hypoglycemia may also lead to the convulsions and everything, but it will then start in the early part of infancy. Yes, Abhay sir.
No, but it's hypoglycemia. I want to stress the hypoglycemia.
Yes. Yes, very nice. Go ahead.
Child is immunized till date. At the birth, OPV, BCG, and hepatitis B was taken. BCG scar was present. At 6th and 14th week, appropriate vaccination was taken. At 9 months, MR taken and vitamin A was given. At 1.5 year, child was scheduled for vaccination. Child age is also 18 months. So booster 1 is pending for this child.
Okay, you have asked for the travel history.
Yes.
To rule out the Japanese encephalitis, as it is not given in the Gujarat, your state. So what is the age at which Japanese encephalitis is given and the age where it is prevalent in the patient?
Ma'am, first dose of Japanese encephalitis is given at the age of 9 months.
Yes, you are right. Yeah, then.
And it is prevalent at what age of
What
the
is,
patient?
yeah, what is the age group?
Early childhood, sir.
Up to what age it is most common?
No idea, sir.
So Abhay sir can give us a
Yeah.
better idea about it.
Yeah, so it is most common. It is common in. It is fortunately not there in Gujarat, but it's a very dreaded disease, very high mortality, and nearly those who are survivors, they are almost have a very long-term morbidity. Number one, and second thing, it is most common below the age of 15 years. So it's a disease of the childhood, but fortunately, it's a vaccine preventable disease. That is most of all. So it is the commonest age group is below the age of 15 years, and it is common in UP, Bihar, West Bengal, Assam. It is not there in Gujarat. That is it.
Yes, thank you so much. And at here, I want to thank Dr. Harsh sir to join the platform. We have already introduced about you, sir.
Thank you. Thank you,
but-
ma'am.
Yeah, welcome, sir. And I also thank Dr. Anand Keshwan, sir, to join the platform. Sir, we will be glad if you are helping the students and also guiding the student for the case.
Okay, I'll try. I'm traveling. I'll try to do.
Yeah, thank you, sir. Yes, you can continue, Aarti.
Developmentally, child have achieved all milestones according to age, and developmental percent is 92 for this child. The requirement of calories, expected requirement was 700 kilocalorie, and child was taking 490 kilocalories, so deficit was 210 calories per day. Protein requirement was 14 grams per day according to age of the child, and child was taking 8 grams, so deficit was 6 grams per day.
9-3-1-2 नए में अहमदाबाद से चलकर वडोदरा को जाने वाली उसी
Yogesh,
तरह क्रमांक
just a minute, let me see whose mic is.
कृपा करिए दानापुर
Yogesh, sir, please mute yourself.
नए में अहमदाबाद की आउनारी
Yogesh, sir, please mute yourself. Yes, thank you, sir. Aarti, go ahead.
Yes. Child was staying one room with kitchen, kacha house, common toilet, bathroom. Father was laborer with monthly income of 8,000 to 10,000, primary schooling done. Mother was laborer 5,000 per month with monthly income, and no schooling was done. According to modified Kupu Swami scale, comes under class 4, which was upper lower class. So, summary.
Yes, go ahead.
18-month-old child, second by birth order, born of non-consanguineous marriage, presented with fever, decreased activity, and 1 episode of convulsion, with normal development in a fully immunized child with inadequate calorie intake, with no history of TB contact, but mother was having complaint of cough more than 2 weeks.
Yeah. So, Dr. Aarti, what do you mean by history of contact? What is TB? History of TB contact? Can you define what is TB contact?
So contact is the person who is who is exposed to a person with tubercular disease.
Mm. But suppose a
Between
person, mother has
children,
a father, mother, neighbor has TB before 5 years. It is TB
2 years
contact.
of duration, sir,
Yeah,
2
so the
years.
duration is very important. It should be within 2 years, right? And especially when the case is open case or a sputum positive, smear positive, it is going to be more infectious. If there is cavitary lesion in the lung, it is going to be more infectious. So TB contact means last 2 years, within 2 years, that is most important. Now, here you have used the word decrease activity. So what do you mean by this decrease activity?
So mother was saying that child was actually playful initially, has achieved all milestones playing with other kids also.
Hmm.
But after starting of fever, within 1 week or so, a mother had noticed that child was mostly lying on bed,
Hmm.
awakening, conscious, definitely, but not so playful. And
So he was not playful, he was not that active, right? But he was able to move the limbs all, right?
yes, sir.
So it
Yes,
does not
sir.
indicate any paralytic lesion. What I want to emphasize that, right? The decreased activity is a generalized term. It's right, not
Yes.
pertaining to any CNS involvement, right? Yeah.
No, yes.
Okay. And the fever is, I think, for 40 or 15 days, right?
Yes, sir.
Okay. Please go ahead.
15 days.
Okay.
I think in summary, you can mention the duration of the fever and all the symptoms.
Mm.
And also better to, use the adjectives while summarize the patient. So in this patient, you want to label as acute, subacute onset, whether it is febrile or non-febrile, encephalopathy is there or not. And this kind of a seizures, it's better to, we can use a focal or generalized seizure, even the description also in this summary also. That will help us to, to put a syndromic diagnosis, and then we can go on further the etiological workup.
Okay, sir.
So mention fever, but you have to rightly said fever for 2 weeks, right? This is actually like for 7 days, something.
7
So
days.
it will help to narrow down our spectrum of diagnosis. Yeah.
Yes, sir. On general examination, child was sick looking, lying on bed, not oriented to time, place, and person. GCS score was 12/15. Severe pallor was there. No icterus clubbing cyanosis or lymphadenopathy or edema. Temperature was 98.7 degrees Fahrenheit. Pulses were 98 per minute. Good volume. All peripheral pulses well felt. Respiratory rate was 30 per minute. BP was 102/60 millimeter of mercury, between 98 to 95th centile. Saturation was 98% on bromide.
Okay, so Aarti, in the general examination,
Yeah.
what are the points you want to see in this child, which is favorable to your the diagnosis in your mind? Because after the history, you haven't mentioned any differential diagnosis. What is there after your history? So you have something in your mind. So what are those diagnoses in your mind, and what you were looking for in the general examination?
So, ma'am, the child was having fever with decreased activity with history of convulsion. So, I would like to rule out meningoencephalitis or any encephalopathy with any abnormal posturing in general examination, with symptom with raised ICT symptoms, or then AF is open or not. Blood pressure, if it is in higher side or normal. GCS score, so that child is having prognosis. What will be the prognosis according to GCS score? Bradycardia is there or not to rule out raised ICT.
Okay.
So Dr. Aarti, you said, yes, Dr. Narendran, please.
नहीं sir, તમે પૂછો.
There is no icterus. So what is in your mind when, if suppose icterus is present and child has this febrile encephalopathy, what will be in your mind?
Sir, acute liver failure, hepatic encephalitis like picture we can rule out.
Yeah. So which are the condition where there is icterus and encephalopathy?
Acute liver failure.
No, some, yeah, that's okay, hepatic encephalopathy. But which are the common infection where icter is
Malaria, sir. In malaria, if ongoing hemolysis is there,
yeah.
there also we can get hemolysis with encephalopathy like
Even in
pictures.
simple viral hepatitis A, we can have this hepatic encephalopathy and encephalopathy and this icterus, right? So common viral hepatitis, our malaria, yes, child is having severe pallor. So pallor, icterus and encephalopathy, it can be cerebral malaria as well. So it has also CNS manifest, right? So now we have got lymphadenopathy. So which are the conditions where there is encephalopathy and lymphadenopathy?
We have other students also in the platform. So
So
anyone
anybody,
in the students,
anyone can
yeah,
participate.
they
Yeah.
can answer. Yeah.
Can TB has encephalopathy and lymphadenopathy?
Yes, it can be, sir, because
Can be a disseminated tuberculosis, right? It can be.
disseminated tuberculosis. Yes, sir.
So, hence, what is other lymphadenopathy and this febrile encephalopathy there? Dr. Harsh, would you like to comment?
Yeah, sure. So there are certain viruses which can have the similar presentation.
Yeah.
Even the rickettsia can have a
Yes.
lymphadenopathy. EBV can also have
EBV, yeah.
a lymphadenopathy and the encephalopathy. I would also like to make clear that what we consider as encephalopathy and encephalitis. So can you tell me the definition, Dr. Aarti?
Sir, encephalopathy is mainly involving meninges. Encephalitis is mainly inside the brain, which is involving cerebral cortex.
Fine, I won't agree with that. So encephalopathy is a general term. Any patient who is present with altered sensorium is encephalopathy. It could be any cause, infective, non-infective, metabolic, toxic, irrespective of anything. Even simple hypoglycemia, hypocalcemia can cause encephalopathy. When you use the term encephalitis, then you are very specific to labeling them as an infection or inflammation. So when you use encephalitis, the encephalopathies result from the infection or inflammation. Okay.
So in encephalopathy, cause can be outside or central nervous system as well.
Yes, sir. Yes, sir. Definitely. Definitely.
And second, Dr. Aarti or any medical student. So when you clinically say the child has predominantly meningitis, and when you say the child has predominantly encephalitis, from the history or physical examination, which are the pointers that will tell you that probably I'm dealing more with the meningitis and less with encephalitis or vice versa?
Sir, if history suggestive of viral infection, it is more favorable during encephalitis. If history suggestive bacterial infection, in encephalitis, the presentation will be acute onset and sudden worsening of condition. In meningitis, low grade infection, maybe bacterial infection with long course will be there.
No, but clinical pointers. I have got one child of meningitis on bed number 1, and in bed number 2, I've got the encephalitis. So what would you expect from a bed number 1 patient and from a bed number 2 patient?
Sir, encephalitis patient will be more irritable
Mhm.
compared to meningitis.
So in meningitis, there is inflammation of the meninges, right? So which may have encephalopathic component, right? So in encephalopathy, usually there is an altered sensorium, convulsion, right? Whether in meningitis, usually there will be in urology there will be more of a headache, photophobia, and the meningeal sign will be present. Whereas in case of encephalitis, meningeal signs may not be present, right? Yeah. Please go ahead.
On head-to-toe examination, anterior fontanelle was closed. No other abnormality detected in eyes, ears, or nose. Oral cavity and mouth was normal. No neck swelling and limb and spine was within normal. Genitalia normal. Both testes in short term, Becken's fine normal.
So
And
in when the
progometric.
antefontal is closed, what would you expect in a child when the antefontal is closed if the child has got the increase in the tension? Is there
So
any other?
child will have complaint of vomiting, headache.
And on examination of cranium, would you get something?
Yes, cranial nerve involvement, commonly 6 cranial nerve.
What is
6 or
crackpot
7.
sound? What is crackpot sound?
Sir, if there is intracranial tension in open air, so on percussion, the sound will heard it is crackpot sound.
Yeah. Okay.
Anthropometry, the observed height is between second and third standard deviation. Weight is 7 kg, which falls less than third standard deviation. Head circumference was 46 centimeter, which was between -1 and second standard deviation. Mid-arm circumference was 11.3 centimeter, which was suggestive of severe acute malnutrition. Weight for height for this child was less than third standard deviation, which was suggestive of severe acute malnutrition.
So you said that it is a severe acute SAM, right?
Yes, sir.
So if you look at the algorithm of the diagnosis of tuberculosis meningitis, NTEP, they have specifically mentioned that the severe acute malnutrition is one of the criteria
Yes, sir.
to have more chances of having this tuberculosis meningitis. So it is again one of the important strong we have got evidence, yes, that this encephalopathy or conversion may be because of some underlying TBM, right? Yeah.
So Dr. Aarti, 1 minute on the anthropometry.
Yeah.
The child is having around -3 SD height, -3 SD weight, and also the weight for height. But the head circumference is not affected. So, any comment on it?
Ma'am, in acute condition, child is 18 months also, still before that child has achieved normal head circumference. So if it is chronic condition, the head circumference would have been affected, or any CNS involvement like space occupant lesion. In that condition also, head circumference would have been increased. So, and weight and height is affected is mainly due to malnutrition, due to chronic malnutrition.
Okay, but we generally say that the brain growth is affected up to 2 years. Okay, so the head circumference in your examination is not affected much. It is between -1 to -2, but not like other parameters of -3. So it is not coming into the microcephaly. So what are the general common causes of microcephaly?
Ma'am, it can be congenital or acquired causes. For congenital causes, hypoxic ischemic encephalopathy or craniosynostosis. In acquired causes, HIV infection, acquired immunodeficiency syndrome.
Any torch infection may
Zika
cause
virus, cytomegalovirus infection, sir. Zika virus infection will also have significant microcephaly.
What is the difference between the microcephaly, which is presenting because of Zika virus, and because of other causes? I'm asking just because you have mentioned Zika virus.
Ma'am, it is acquired microcephaly.
It's acquired microcephaly or it's congenital microcephaly? Zika virus infection.
Congenital, ma'am, due to congenital.
So the child is having significant microcephaly at the time of birth. Okay, go ahead. Harsh sir, any comments you want to do?
No, I think you can go ahead. Yeah.
On nervous system examination, higher mental function, GCS score was 9/15. Altered sensorium, irritable cry with drowsy in between, not oriented to time, place, and person. On cranial nerve examination, first could not be tested. Second, visual fixation or field of vision could not be tested. Fundus examination was normal. On third, fourth, and sixth, pupils were normal in size and position. Reactive to light, extraocular muscle could not be assessed. On a fifth cranial nerve examination, bilateral corneal reflexes preserved, sensory and motor part could not be tested. On a seventh cranial, facial symmetry was normal, which was observed while child was crying. On eighth cranial nerve could not be assessed, but responding when mother was calling to the child. Ninth and 10th uvula was centrally placed with symmetry. 11th and 12th cranial nerve was not could not be assessed, but no on examination no fasciculation or atrophy of tongue was noted.
So, one minute, Dr. Aarti. Altered sensorium and irritable cry. What do you mean by this irritable? I think in the literature or in the book, there is nothing like irritable cry. So child is irritable and in between drowsy, you can mention like this, right?
Okay.
So just it is. But I want to know what is the importance of this cry here? Which type of different cry you would expect in a CNS, in a neurology case?
Inconsolable cry, sir.
No, that is the one. Yes, second. Still, I am specific cry.
High pitch cry.
Yes, high
In
pitch
younger
cry,
age.
shrill cry. That is suggestive of increase in tension. And if the cry is feeble, probably the child might have some lower motor illness or something like that. Flexid illness is there. So it is very important. So there is nothing like irritable cry to the best of my knowledge. The child is irritable when approach or in between and becomes drowsy. That is a better, I think, sentence. Because this small thing will disturb you. If you do
Yes.
irritable cry, there is nothing in the book like irritable cry. So right.
And in the encephalopathy patient, you can also assess the extraocular movement by eliciting the Doll's eye maneuver.
All side movement, yeah.
You can write and mention that. So definitely you can do that. Okay.
Okay, sir. Okay.
Mhm.
On motor system examination, bulk of muscle was examined when child was lying in supine posture. Posture was supine. No muscle wasting or atrophy was noted. The muscle girths on both the sides are equal and normal in size and shape. Tone of all four limbs were hypertonia. Power of left upper and left lower limb was 3/5, and right upper and lower limb was also 3/5.
So Dr. Aarti, you say the bulk of the muscle. So if suppose the calf muscles are very much bulky, then what would you expect in a child and which sign will you do to find out whether any neurologic involvement is there or not? Mainly proximal.
Muscular
Yeah. So it is-
dystrophy,
yeah.
Duchenne muscular dystrophy, and Baker's muscular dystrophy. And for that, we'll ask the child to stand up from sitting position. If child is not able to do Grover sign, sir. If child
Yeah,
is
so
not
it is very important. So
Grover.
if the child muscles are bulky, but the strength is not there, there may be some lower motor illness like Duchenne muscular dystrophy. Yeah, okay, please go ahead.
And how confident you label a power in encephalopathy muscle, encephalopathy patient?
So for these patients, power was at least 3/5. Because against resistant, I couldn't elicit. So by 3/5, it meant at least 3/5. It could be more than
Yeah,
that, but
so-
definitely.
Yeah, so encephalopathy patient, it doesn't help that much, but at least you can see there is anti-gravity movement is present or not. You cannot, it's not so wise to label or grade a power. Okay.
Reflexive, superficial reflexive, abdominal and symmetric were normal. Plantar reflex was extension of great toe with fanning of all four toes. Deep tendon reflexes, bicep were +2 in both limbs, triceps were +2, supinator were +2. Knee reflexes were +3 in both limbs, and ankle was +4. Ankle clonus was absent, and patellar clonus was also absent.
So plantar extension, which type of the lesion is there?
Plantar, pyramidal tract involvement.
No, what I want to LMN or UMN?
UMN, sir. UMN.
So what is the difference between UMN and LMN lesion?
In UMN lesion, the lesion is between cerebral cortex to anterior horn cell, and in LMN it is below anterior horn cell. In UMN, usually clonus present. In LMN, it is absent. Plantar extensor in UMN and normal or absent in LMN. So
Very
in
good.
UMN, hypertonia, hyperreflexia will be there. In LMN, hypotonia and
Yeah.
normal
So
reflexes
these
mostly.
are all basic things. They are usually frequently asked in the exam, huh? Yeah, please go ahead.
Meningeal signs, neck rigidity was present, turning and Brudzinski were positive. Back and spinal examination was normal. So summary for this patient, 18-month-old boy born of non-consanguineous marriage presented with complaint of fever for 14 days, weight loss and seizure and decreased activity from last 1 to 2 weeks. The child belongs to lower socioeconomic state with complete immunization with a calorie gap of 210 kilocalorie as per nutrition history. He has severe acute malnutrition as per WHO with severe anemia and no signs of vitamin deficiency. The child is irritable, drowsy, not oriented to time, place, and person, with hypertension, hypertonia, hyperreflexia, and extensive plantar response with positive meningeal signs suggestive of meningeal involvement. There are no other systemic involvement.
Yeah, so before we go to the diagnosis, you mentioned about the no sign of vitamin deficiency. So which vitamin are usually associated with such type of the neuropathy? Which deficiency?
Vitamin B6 deficiency, sir.
Yes, then
B12
yes,
deficiency.
exactly. Yeah, yeah. And what happens to vitamin A? Overdose of vitamin A. Again, it was CNS symptoms. Pseudotumor cerebritis,
Hypervitaminosis, yes, sir.
right? Yeah,
Pseudotumor
so they are
cerebritis.
very important as far as CNS is concerned. Yeah. Dr. Harsh, you can comment in between.
Yeah, sure. So how do you categorize or how do you summarize this patient, this entire summary into 1 or 2 sentences or 1 or 2, with headings? So how would you approach this child? Under what heading? What will you consider?
So the history suggestive of mainly acute meningoencephalitis syndrome. So I would like to further investigate in in direction of meningitis or meningoencephalitis.
Fine. So in CNS, the adjectives are very important. They are very helpful. So you have to, the ODP, as we tell, that origin, duration, and the progress. So you have to categorize whatever the symptom onset, whether it is acute, subacute, chronic, whether it is progressive or non-progressive, and what exactly child has, under what heading. So in which we can definitely consider encephalopathy and more specific encephalitis. So even now that you have examined, there is a meningeal sign is present, then definitely we are dealing with the meningitis. So either you are dealing with the acute meningitis, subacute meningitis, or chronic meningitis with given history.
Sir, acute.
Why acute?
Because for chronic, it should be at least for more than 4 weeks.
Yeah, true. For acute, how much?
Less than 15 days.
7 days.
Fine. So 7 days is considered as acute.
This subacute onset. This first
7, yeah, this
This-
is subacute onset. Yeah, exactly.
This subacute. This is subacute onset. Yeah, 14.
Okay.
Okay. So subacute febrile
The
encephalopathy.
onset is
specific for
subacute.
acute.
Child has got the fever. Means the child has some either infection or inflammation. Now, which
Yes.
system is involved?
Central nervous system, sir.
Yeah. So we are dealing with some subacute or acute to subacute insult, infective or inflammatory insult to the central nervous system. That we can comment up till now, right? Yeah.
So differential diagnosis for these two cases: tubercular meningoencephalitis, pyogenic meningitis, or partially treated pyogenic meningitis.
So why consider first in differential as a tubercular? Why not pyogenic or partially treated pyogenic?
So for pyogenic meningitis, the course will not be this much long, first thing. And second, child is severe acute malnourished. Family history of chronic cough in mother was also there. So that was favoring towards tubercular meningoencephalitis rather than pyogenic.
Fine. But I think you told the mother he has a history for 2 weeks.
Yes, sir.
I don't think so. 2 weeks will consider TB in 2 weeks of cough history.
No, sir.
Then why not pyogenic meningitis as the first differential?
Sir, for pyogenic meningitis, the presentation of seizure or convulsion will be in early phase than tubercular meningitis.
Fine. So yes, so in beginning, if any febrile infection, the antibiotic has been given. So the child, the entire natural course can be modified. They may present in the even second week of also as a focal deficit or seizures also. So in this case, when you have a subacute history, it is not that much very prominent to have a TB as the first or to be the first thought should be come into our mind. So we need to consider as if the child has already received the history of antibiotics, then we need to consider as a partial treated as a first differential. The followed by we can consider definitely as a TB and other chronic meningitis cause. So TB is usually a part of chronic, not the acute presentation, although we do see acute presentation also, but by in general or in routine or as a norm, it's a part of a chronic or a slow evolving process, Okay.
Okay.
So if you look at our new criteria, which are the points in your history and everything that favors the diagnosis that yes, it is more likely to be and not the partially treated septic meningitis. You analyze the
Sir,
total case, which are the pointers that is more in
Sir-
favor of TB meningitis.
sir, first of all, in criteria 1, the duration of fever was more than 5 days.
Yeah, so it
Child
is
was
subacute to
irritable.
chronic concept. Yeah, number one. Then
Second is, sir, child was lethargic and decreased activity. History of convulsion was there. Then,
it can happen with any infection, like including acute pyogenic meningitis, bacterial meningitis. So it is not a pointer for tuberculosis. Second,
the severe acute malnutrition
yes,
is favoring towards tubercular meningitis.
yes. Then third,
Low grade fever, sir.
low grade fever. Yes. Fourth, you mentioned your history. It is very important.
The recent history of weight loss.
Yes, weight loss. So weight loss. So any child who has got the unprecedented symptom of more than 2 weeks, fever or cough, weight loss. What do you mean by weight loss in TB?
Sir,
Suppose-
more than
Yeah, that is
more
important.
than 5% of weight loss or not gaining weight
Yeah.
with
So it is also important. And severe acute malnutrition. This is does the child was having BCG scar?
yes, sir, BCG scar
So
was
it is also if BCG scar is absent, then probably it is also one of the important because it will not
Yeah.
protect the child from hematogenous complication of TB, right? Like TB and miliary tuberculosis. Okay, please go ahead.
investigation. Routine investigation were done in which HB was 6.10, counts and platelets were within normal limit. ESI was 26, CRP was 4.8. Blood culture and HIV antibodies were negative. Urine RMCS was normal. CSF study was within normal. Gastric aspirate for CB-NAT was sent in which Mycobacterium tuberculosis was diagnosed, which was rifampicin sensitive, and tuberculin skin test was positive. On other electrolytes, sodium was on lower, 122 milliequivalent per liter.
So the child has got hemoglobin 6.1. So what are the common causes of anemia in a child who is 1.5 years old?
Nutritional anemia, sir, B12 iron deficiency anemia mainly. At 1.5 year old, thalassemia can also be
Yeah.
there. Sickle
So-
cell anemia.
Yeah, so if the child has got anemia, knuckle pigmentation and tremors, then what would you call it as?
Infantile tremor syndrome.
Yeah,
B12
that is-
deficiency.
Now, if anemia is there, what is commonest infection which causes anemia and encephalopathy? Very common in our country. Now we have decreased the frequency of cases, but it is very common day-to-day cases. When we were the student, it was a day-to-day cases. All febrile child with anemia was having a typical diagnosis.
anemia and encephalopathy.
Any encephalopathy or anemia and fever in that matter.
Anemia and fever, malaria.
Malaria, yes. So it is malaria. So it is very
Malaria.
important. So sometimes what happens is when the child has got this type of the dreaded illness, even if the malaria parasite is absent, sometimes we empirically start anti-malaria therapy in such cases because we want to save the child, right? That is very important. Now I think I'm not happy. Dr. Hurst is a better person. CSF is only cell is only
Yeah,
five.
yeah. True. So I was just about to ask this thing. What would you expect in a typical
Yeah,
case of
yeah.
TBM as a CSF findings?
Sir, in TBME, cells were between 5 to 100. Protein will be on higher side more than 100, and sugar will be less than 0.5 or less than 50% of random blood sugar at the time of CSF.
So what was the blood sugar at that time you did it here?
102 milligram per liter.
Are you sure? Because I am, why, what is, suppose if sugar is low in compared to this blood sugar at the same time, so I think what would you, what will favor it? Would you go? So it is more in favor of pathogenic injuries, because if the sugar is low and cells are not that much high, I think it's one of the most important clinchers. So it is here, blood sugar and CSF sugar ratio, you have to mention it. You have not mentioned it, but you have to, it is a must. And yeah. Achha, HIV antibody, suppose HIV antibody is positive, what will reflect? That means the child has HIV infection or something else, because child is only too young. Suppose a child who is 6 months or 8 months, that HIV antibody is positive, reactive. How will you proceed?
So it can be maternal infection.
Exactly. So it is also a very important part that maternal transplacental passage of antibody has to be considered, and you have to go for the PCR test. This serological test may not be helpful in a young infant, right? Yes.
So,
yeah, please first.
Yes, sir. So in TBM, definitely. So what you have told, that's true. So basically the clincher is, it's a relative less pleocytosis with more hypoglycemia. That is how TBM usually plays. And they have a very good amount of high protein. Now, suppose if this child having a TBM with this kind of a CSF picture, how can you explain it?
Sir, maybe low viral load or no bacterial load. No.
Fine.
Early
Okay.
phase illness.
Yes, one early phase.
Why proteins are increased in tuberculosis?
Yes, yes.
It will give the answer to this, what Dr. Hurst sir is telling.
So due to bacterial engulfing in meningitis, there are release of caseous material which is protein rich.
First, please clarify.
Yeah, sure. So yes, you are right in a bit way. The basic pathophysiology of TBM is there is a we can say there is exudate with form,
Yeah.
basically because of the inflammation rather than bacteria itself, and they cause a increase in the seepage of the we can say the vascular leaking. There is increase in the protein. There is a basal exudate what we see in the even imaging also. And sometimes this process start before that. Most of them, some of the patients are presenting mainly with tuberculoma. They have a very good immunocompetent reaction. They bound the cells or the organism in the very defined spaces. They may have a vasculopathy more prominent than the proper TBM what we see. In this patient also we can expect this kind of a presentation, as we found the TBM bacterial positive. So they basically present as a TB vasculopathy or tuberculoma rather than proper TBM or meningeal picture what we used to see in a majority of the patients.
So Dr. Aarti, have you sent this CBNet CSF only? You sent only gastric aspirate or the CSF?
So CBNet CSF was also sent, but it came negative.
Yeah. Now suppose one sample of aspirate is negative. So what is the current recommendation of sending how much samples?
2 samples ideally.
Very good. Yeah. Yes. Please go ahead.
MRI brain was done, sir,
Mm.
which was suggestive of diffuse leptomeningeal enhancement involving bilateral cerebral and cerebellar hemisphere, and along with basal system suggestive of changes of meningitis. Few tiny enhancing nodules seen in bilateral cerebral hemisphere and the right cerebellar hemisphere suggestive of tuberculoma likely. Mild hydrocephalus was there. Acute non-hemorrhagic infarct involving left gangliocapsular region and head of left codex nucleus and bilateral frontal lobe, left more than right, in a paramedial midline location. Both findings collectively suggestive infective etiology, cough slightly with vasculitis infarct.
Yeah. So
Can you put the
yes.
MRI images?
Yes, sir.
So the for a learning purpose, this is the first image is what you see. You can see, yes. So second row, yeah, you can see there are the hyper intense lesions. So white lesion you can see.
Mm.
You're able to see, and the corresponding the below images, the third row from the below, you can see corresponding black shadow of that white images, white lesions.
Yes.
Can you put the cursor there?
Yes, sir.
Yes, the black one you can see the second row in the upper from up the second row, the fourth figure. Yeah, you can see there is a white lesion.
Yeah.
Okay. And the corresponding there is a black shadow from the third row from the below. That this one.
Yes.
Yeah.
Yeah.
So this is we call as a diffusion restriction. So you can see there is a in the left caudate region is there, and there is a corresponding there is a diffusion restriction. So this called as a cytotoxic edema, which usually present in the infarct. So any patient presenting with a stroke also we can see this finding, or any reason of vasculopathy or vasculitic lesion can have this finding. So this is called as a diffusion restriction images. The white part and the corresponding ADC images, which have a corresponding low area or we can hypointense area, that is both together consistent with the cytotoxic edema, which usually we believe that it is because of the vascular pathophysiology.
So Dr. Harte, which are the common pathological changes in tuberculosis meningitis? 1, 2, and 3. Which are the areas commonly affected?
Sir, leptomeninges, basal
Which
exudate,
part? Yes, basal exudate. Yes.
and vascular involvement.
Yeah, vascular. Yeah. Then hydrocephalus is common.
Yes, sir.
Yeah. And fourth one is a tuberculoma, what Dr. Harsh Patel has said, right? Yeah. So basal exudate, hydrocephalus, tuberculoma, and vasculopathy, right? These are common features. And what is there in acute bacterial meningitis?
Sir,
Of course, in a complicated, there will be a general meningitis.
dilatation of ventricle, basal
Ah.
meningeal enhancement.
Then the complications are usually in form of subdural empyema,
Yes, sir.
or ventriculitis, or sinus thrombosis, right? Okay.
Should I
Yeah.
continue?
Proceed, yes.
MRI of brain with contact.
One minute. What are this ring enhancing lesion? What is the commonest nearest difference diagnosis, I would say?
Tuberculoma with a neurocystic sarcosis.
Yes, very good. Oh. Good.
So the child was on admission, airway breathing and circulation was maintained, airway speed was started. Considering his acute encephalitis syndrome, antibiotic, antiviral, and anti-malaria treatment was started with higher BP. So injection mannitol was also started. Injection Levipil was loaded with maintenance too. And after getting the reports of CBNet, AKT was started and injection dexamethasone was also started.
So you are now treating a case of tuberculosis meningitis, right? So once you've got the diagnosis, would you like to continue the ceftriaxone, artesunate, and acyclovir?
No, sir, ceftriaxone was continued, but artesunate and acyclovir were stopped after 3 days.
And for what is the duration for this antitubercular therapy?
Sir, intensive phase 2 months, continuation phase 10 months.
And steroid for how long and in what dose?
4 weeks continuation, 4 weeks. If prednisolone, we are giving 1 to 2 mg per kg per day, and next 4 weeks tapering dose. And if dexamethasone 0.6 mg per kg per day, and then for 4 weeks, and then tapering dose. Next 4 weeks.
Yeah, and which are the indication of the steroids in tuberculosis other than CNS tuberculosis?
Sir, TB pericarditis, TB uveitis, miliary tuberculosis, TB meningitis, Addison disease.
Yes.
Alveolovascular
Okay,
block.
yeah.
Alveolovascular.
Yeah. Okay. Yes, Harsh, please go ahead.
I think yes, that's true. So we'll start with the dexamethasone. When there is a hydrocephalus, what would you like to add in this management, or this management will suffice to handle it?
So for hydrocephalus, we can add acetazolamide.
Yes. Acetazolamide you can add. And when you consider operative intervention, if at all it is required?
Sir, after starting the treatment, if hydrocephalus is persisting in increasing, or if symptoms are not relieved, increase in head size, then we can consider ventriculoperitoneal
So
shunt.
how would you reach to a conclusion clinically that hydrocephalus is increasing or not responding to your medical management?
Sorry, sir.
How would you know clinically that patient is hydrocephalus is not relieving with your medical management? What are the clinical signs?
Concept sign or worsening of symptoms.
Worsening of which symptoms? How would you know?
Raised BP, bradycardia with hypertension with irregular respiration.
That is at a late stage, no? Which are the symptoms? Have you admitted this patient? If you have started the treatment, you are not getting better improvement in terms of what improvement? Persistence of fever, persistence of CNS symptoms. If CNS symptoms, then which CNS symptoms?
The fundus abnormality,
Right.
radial nerve involvement.
Fine, yeah. So worsening of encephalopathy, the patient having the posturing. Okay. Sometimes what happened that posturing falsely treated as a seizures. But when there is your decorticate or cerebral posturing, that is a part of raised ICP. So in any patient who is suspecting TBM, you should always look this kind of a signs. Definitely when the AF is open, you can definitely look for the AF bulging, tense bulging, and also the head circumference measurement also would be helpful. But after closing, when there is a raised ICP which is not responding to the medical management, then definitely this kind of a symptoms will help you to understand. And if there is a presence of papilloedema with hydrocephalus, definitely you have to seek the opinion of neurosurgery. Okay.
So your sodium was only just 129.
Yes, sir.
Sodium level. I think it is 129, quite low. So is there any relevance with any CNS infection in hyponatremia? And would you like?
129 usually will not present with symptoms. So
Sir is asking why there is a low sodium in this current clinical scenario. Is there any significance or is there any correlation between that?
sir, any salt wasting, CNS salt wasting symptom, anything.
What is more common than as soluble salt wasting syndrome?
Sir, SIADS.
Yeah, exactly.
Yes, that is.
So how you can define or how you can label or prove the SIDH? What would you measure? in terms of investigation.
Investigation.
Sir, serum and urine osmolality.
Yes, exactly.
Yes, exactly. Second, Dr. Aarti, you have empirically started ceftriaxone, that is to cause acute bacterial meningitis, right? Number one.
Yes, sir.
Then why have started this acyclovir?
Sir, considering it acute encephalitis syndrome can be due to bacterial or viral or due to malaria.
No.
So cover
Ceftriaxone is for acute bacterial meningitis. Acyclovir will cover which organism? For what is in mind when you start acyclovir?
herpes simplex virus.
Yeah, so it is the commonest cause of sporadic encephalitis. We just got the antiviral, specific antiviral therapy. And that is why we want to, though it is not that common, but would like to cover it. So which part of the brain is affected in herpes simplex? And what was the clinical presentation?
Sir, commonly temporal lobe involvement.
Mm.
And,
You got MRI also.
hearing.
MRI, what is the finding in MRI if it is a herpes simplex? Dr. Hers, please.
Yeah, so you're right in telling the temporal lobe. So most common involvement is the temporal lobe, with internal and external capsule can also be involved. And it can be unilateral or bilateral, and sometimes hemorrhagic lesion can also be formed. In the so this is very commonest cause of viral encephalitis.
And sometimes CSF can be hemorrhagic as well.
Hemorrhagic, yes, exactly.
So how will you prevent tuberculosis?
Sir, if patient is having fever and cough for more than 2 weeks, NTP, according to NTP goes early diagnosis. If patient is positive, any person is came positive, family screening to prevent and treat other family members if they have. And
Yeah. So there
so
are
mainly BCG vaccination.
two different BCG vaccination, and other is a chemoprophylaxis, right? Yeah.
Chemoprophylaxis.
Now, number one, second thing, CBNet. What is the advantage of CBNet?
Sir, it's a cartridge-based
Mhm.
nucleic acid amplification test in which with positivity of Mycobacterium tuberculosis, we can also get rifampicin sensitivity or not. And the result we can get within 2 hours with
Yeah, so
higher
turnaround time
sensitivity
is
and
very fast. That is very, very important. Yeah.
yes, and the sensitivity and specificity is also more than 98%, almost more than 98%.
Very good. Yes. Yes, Harsh, you can proceed.
Yes, so fine. I think we have covered the almost all things. So which other differential would you like to see when you suspecting clinically TBM in terms of other infection? Which kind of a chronic infection would you think? In this patient, when you have a severe acute malnutrition or you have a chronic presentation, which other infection would you like to consider?
HIV, sir.
Yes, definitely.
Second, then which are the
Klebsiella or Pseudomonas in immunocompromised state. Opportunistic infections.
which opportunity infection?
Pneumocystic carina, PCP.
But in CNS, cryptococcal meningitis, have you heard?
Yes, sir. Cryptococcal
Okay.
meningitis.
Okay. Okay. So
Yes, yeah. Fungal infections are the other differentials we can give. Yeah.
So how will you follow this case of tuberculosis meningitis?
Sir, after history and examination and after investigation, we'll start a treatment with antituberculin therapy
Hmm.
with intensive phase with isoniazid, rifampicin, pyrazinamide, and ethambutol for 2 months, and then a continuation phase with isoniazid, rifampicin, and ethambutol for 10 months, along with steroids for total to 8 weeks. And along with pyridoxine supplementation to prevent B6 deficiency, and adequate nutrition advice for appropriate weight gain. And
Yeah, one is the weight gain. Then one is the child should be symptom free, means convulsions, the level of concern will improve, right? And the third one is the weight gain. Would you look at the side effects of the drug?
yes, sir.
Yeah. So which are they?
Sir, ideally every 4 to 8 weeks, liver function test should be done, as isoniazid, rifampicin, and pyrazinamide have hepatitis.
Yeah. So we have to look for the hepatotoxic liver drug induced liver injury, right? Yeah. Right. So what is the level of SGPT that says the child has got the drug induced liver injury? Suppose the
Yes,
SGPT normal value is 40, and if the child has got the 50 SGPT,
No,
would you
sir,
stop
3
the
to
drug
4
or is there
times,
some criteria?
for at least 3 to 4 times of normal value.
Yeah. So if the child is symptomatic, it is more than 3 times. And if the child is asymptomatic, it is more than 5 times, right? Okay. So Dr. Nehalban, you can take over.
So, Harshbhai, anything to be discussed now, or we have completed?
I think we have completed almost all the aspects that has taken up the most of the things. So yes, I think
Only
any
thing that if,
questions,
if suppose Harshbhai asks for a repeat MRI and the child is clinically improving, but if there is an increase in the size of tuberculoma, what is
yes,
your
yes, yeah,
interpretation?
that is it.
What is your interpretation? I'd say it's a very day-to-day, not that uncommon, I would say.
Yes, yes, true, true.
So I think this is the only part that is left in the discussion.
Yeah, it's
So
a
what
very
is
good
that?
point.
Yeah. Usually in an improving child, we don't go for the MRI, but sometimes out of anxiety or whatever the consultant thinks, and say we do a second MRI. And an improving child, the tuberculoma size is increased, the perilesional edema has increased, and the child is running fever. So what it is would you consider it?
Sorry, sir, no idea.
Any PGs or any other? Harshbhai, please go ahead. Paradoxical reaction.
Yes, yes. So it's called as a paradoxical reaction. It
Yeah.
is different than IRS, which we seen in HIV patient. So this is very common, and it is not an abnormal phenomenon, first of all. So immunocompetent child, if we serially monitor the tuberculoma, if we do a study and serially monitor the tuberculoma, almost around 60 to 70% of the tuberculoma may have a increase in size in a entire course of natural course of that illness. So it's basically be known as a paradoxical reaction. So it's a more immunocompetent or more immune response that will lead to the increase in the size transient, and then will again they regress, and then over a time they will diminishes.
Yeah.
So this is very common, but sometimes what happens that in a crucial area, if there is anatomical area is like that, with increase in the size, they may have a transient symptoms occurrence. At that time, only that particular symptomatic patient, you may go ahead for a transient course of steroids again.
Steroids.
Otherwise, there is nothing to be done. We just need to monitor and we need to reassure the patient.
And the likelihood is more in your case because the child is got the same. Once the nutrition improves, the immunity improves. The child becomes more immunocompetent. So it is very important. And on the other hand, if the child has got worsening and there is increase in the tuberculosis, it indicates that child may have got multi-drug resistant tuberculosis, MDR TB, and the line of treatment remains altogether different, right? Yeah.
Yes.
Yes, and even in the immunocompetent host, if we see the immune reaction, so in chest X-ray of such child which are having tuberculoma in the brain, more common finding into the chest X-ray is miliary tuberculosis.
Yeah.
So that is also one of the prominent association between these two, brain and chest.
And
s-
you didn't show us this X-ray chest, no? It was normal, no?
Yes, sir. Chest X-ray was normal.
Oh.
So we are completing the case discussion here. Today we are completing it at early. But I must thank Abhay Shah sir and Harsh sir for giving an elaborated view, suggestions, and guidance to Aarti for a very nice case discussion. Also, I thank you, Aarti, for preparing the case, taking all the findings in the case so nicely. And I thank Rashmi madam for guiding her through the case with each and every small, minute things. It's very essential for the PG to look beyond the diagnosis also. That is what is required. Generally, we have a diagnosis in our hand and then the vision goes tubular. But to consider all the other things, as the today's experts laid us with so many differential diagnoses and the minute other things around to the case. So I thank both the experts, Rashmi ma'am and Aarti, for presenting the case. I also, there is one question from Dr. Rohan. Rohan, you can ask in the platform by unmuting yourself.
Good evening, sir, and good evening, ma'am. Am I audible?
Yes.
Yes,
Yes.
yes.
Harsh Patel, sir, I want to ask one thing.
Yes, yes.
Can you, sir, throw some light on the higher motor function status? Like, sir, we all, as a postgraduate, we always confused. Is it right to write down conscious in 1-year-old child or drowsy, lethargy, irritable, sir? It is always confusing in the higher motor function. Sir.
Yeah, definitely. So consciousness is a normal thing. So definitely you can write even in the newborn also. As far as the drowsy, the irritable and everything, that is more of the subjective. It may not have a very objective assessment, but definitely you can mention, your opening statement. It cannot be a, you can include whatever you are visible or whatever you are feeling about the child status. At the same time, when you write or when you can enumerate in your CNS examination, then definitely you can you can elaborate the state in a deep way rather than just putting a word as a drowsy or confounded. That should not be there. You have to elaborate overall activity. If there is a newborn, then state to state transition also should be mentioned. If it is an infant, then how is recognizing her mother, especially the mother, the parents, how is interaction with the surrounding environment, that everything should be mentioned in a deliberate manner, in a elaborative manner, what you are exactly seeing and experiencing by looking at the child.
So, sir, most of the time the terminologies where the stupras, covatus, those are still confusing in the clinical practice.
Yeah, true. So if you just write as a child is stupras, then it doesn't convey the what exactly you want to convey to the examiner. So it is better to elaborate it what exactly you are seeing, why you have think about the stupras. So rather than put that ideas into the words, rather than putting in a one word, because it doesn't have any objective parameter like GCS score. Okay.
Thank you so much.
Thank you so much, sir and ma'am. Thanks a lot.
And I think Clarinet.
Well done, Dr. Aarti. Well done.
Yeah, it's a really good presentation. Although case is straightforward, but it's a very nice case, and it's sum up very well.
Thank you so much, sir.
And I thank Clarinet for providing this platform for the PG's discussion and giving the knowledge to each and everybody. So we can end the
Thank you so much, ma'am.
session. Yeah. So we
Thank
can
you.
end.
Thanks to all the doctors. Yes, ma'am, you can continue. Yeah.
You can end the session now. It's okay.
Okay. Thanks to all the doctors for joining on our platform, and I hope to see all of you on the next sessions as well. So with all of your permission, can I conclude the session here, ma'am?
Yeah, please.
Yeah. Thank you. Thank you so much for joining again.